Inflammatory Breast Cancer Foundation presents IBC, Facts and Fallacies, What Your Doctor May Not Know. In today's world, the internet is used by so many. Research is at its fingertips of just about anyone on subjects they may need to know more about. But the challenges of knowing the truth versus fiction about health issues are a major concern for the public and the medical community. With all the hurdles many women face when they may have the symptoms of IBC, and the doctors who seemingly disregard their pleas to rule it out, this show will attempt to educate everyone and help differentiate between what really are facts and what are fallacies. And now, your hosts for tonight's show.
Hi, everybody. Hi, Peggy.
Hello, Patti.
How are you?
I am good.
We're both in turtlenecks. It's the middle of winter.
Yes, it is. And it's very cold here.
This is going to be an interesting night, so we're not going to do the usual jabber that I do the first of the show. I'd like to introduce everybody to Dr. Naoto Ueno. Sorry about that. Who is a professor? There you are. Hello.
Hi.
He's a professor at the Department of Breast Medical Oncology at the University of Texas MD Anderson in the IBC clinic. Good evening, sir. Really good to have you.
Yeah. Hi, everybody. I really appreciate the opportunity to talk today.
We do too. You want to give us some background on you and how maybe you got involved in stem cell transplants? Is it stem cell transplant or is it stem cell rescue?
Stem cell transplant is correct. You could call it stem cell rescue, but I think most people know it as stem cell transplant.
Okay.
So I think it goes back many years ago, probably 15, 20 years ago. There were heydays of many people were getting stem cell transplant for breast cancer. And that's how I started my career. And the biggest reason for getting involved in this is because I really wanted to help people who have aggressive cancer. And this obviously includes inflammatory breast cancer, but metastatic disease, people who have a lot of accelerated lymph node involvement with cancer and inflammatory. In those days, we didn't know if stem cell transplant works or doesn't work, but that was part of my research. So I started my breast cancer career from stem cell cancer transplant.
How long ago was that?
That was probably 16, 17 years ago. Yeah.
Was it a really new thing at that point?
No, I think in terms of what we call high-dose chemotherapy and stem cell transplant really started in the late 80s. I mean, the concept was started even in the early 80s. So when I actually really came into the field, it was really in the middle of many randomized clinical trials were conducted.
Peggy? I bet you $1 Peggy put herself on mute.
Mm-hmm.
Okay.
No, I did not. No, I did not. My Skype is actually...
Have you got some questions you'd like to ask Dr. Ueno?
Absolutely.
Mm-hmm.
One of the biggest ones is what criteria would allow someone to have a stem cell transplant?
Okay, so I think we need to kind of clarify this one thing before we talk about criteria, because the field has really changed because there were really negative perception due to really medical kind of misconduct with some of the investigators. And many clinical trials I talked about comparing high dose versus standard chemotherapy, it was pretty much all negative. So currently, the reason to do these high-dose chemotherapy is really for young people who have disease getting control from basically a standard chemotherapy or target therapy, And then we know that truly that we could achieve the shrinkage of the tumor as much as possible to the point that you don't see it. And if we think that's really the case, those are the people potentially could go on to clinical trials. But I want you to understand that we're not in any position to say that stem cell transplant is a standard of care. It's like any other clinical trials. That's what it is.
And I don't think either one of us even thought of asking you that in the beginning.
Yeah.
I mean, we take it for granted that it is a clinical trial, but
Right.
thank you for saying that.
Right. Because obviously there are many exciting other clinical trials, not just transplant, that exist for including non-inflammatory breast cancer as well as inflammatory breast cancer. So I started as a career involving transplant, but currently most of my activity is also the other activity I spend a lot of time is in non-transplant. It's not stem cell transplant, but trying to develop a unique clinical trial for aggressive breast cancer, which includes inflammatory breast cancer.
When I need to understand this myself. When I hear that you go and you take, I'm going to make this really simplistic. When you take their own stem cells, what do you do with them before you reintroduce them into their body?
So the idea of stem cell transplant in breast cancer is to give a very strong chemo and trying to shrink the tumor as much as possible by additionally giving a stronger chemo. But then when you give that strong chemo, then the bone marrow, which is inside the bone where they make the blood, gets damaged. So meaning that if we just give simply this chemo, strong chemo, it won't recover by its own. So the idea is to collect these stem cells, which is baby blood cells, before you give the chemo. And there's a way to collect this from the patient, and we could store it in the freezer. And once you give the strong chemo, you actually do the transplant. Now, the transplant is not a surgery. It's a simple blood transfusion, and these baby blood cells will find its own way back into the bone, and they will regrow.
So you don't actually do anything physical to the cells that you've removed? Because people say all kinds of different things.
The basic technology, we don't do anything to the baby cells we collect. But some of the clinical trials the clinical trial that we have at MD Anderson, because when you collect the baby blood cell from the patient, the cancer cell could be circulating in the blood, so we could actually get contaminated with cancer cells. So there are technology that would divide these baby blood cells from the cancer cells. So we try to clean this up, and then we put it back. That's the clinical trial that we have been doing.
Okay. So something is done. It's just, is it the simple, stupid again? Is it the freezer? Is it the freezing?
Right. Well, the freezing is just storage, but there's a column that we could use that would separate from the good cells from the bad cells. So one of our colleague, Dr. Cristofanelli, one of his major work is called CTC, which stands for circulating tumor cells. So there are techniques that you could take a little bit of blood from the patient, and you could actually count the number of the cancer cells. And depending on how many cancer cells you have in the blood, it helps to understand how bad the disease will progress or it may not progress. So this tells you that there is cancer cells in the blood. So when I talked about collecting the stem cells, we actually pull the blood out from the patient. The patient will go through the machine, and we collect the cells that we're interested, the baby blood cells. The remainder of the cells, the blood will go back into the patient. So in that blood processing, the cancer cell could get contaminated with the the baby blood cells, the stem cells, so we try to separate this later on so that we don't put cancer cells back into the patients.
So, is the theory then that they would be stronger and have the ability to fight the cancer in the body?
The cells is made will not fight the cancer, but because you're cleaning up contaminated cancer cells out from the blood, it potentially may help to reduce the chance of disease coming back.
Okay.
So you could see that you give strong chemo, try to put the disease to what we call remission, meaning that you don't see it on the surface, and then we clean it up. So because you're not putting back these cancer cells back into the patient, it may help to control the disease longer. We don't know if it will cure, but there's that potential that exists.
Does this work also, besides inflammatory breast cancer, will this work for other types of cancers also?
So it actually started more for metastatic breast cancer. So metastatic breast cancer, so one of the issues in inflammatory breast cancer is that it's very aggressive. And why is it aggressive? Because the disease could come back very rapidly, right? So when the disease come back, it could be located in many different parts of the location. That's what we call metastasis. So metastatic breast cancer, if you go to any breast cancer doctor, they'll say you can't cure the breast cancer, but this type of a clinical trial is intended to control the disease as much as possible with one treatment is the purpose, actually. And this includes inflammatory breast cancer.
Okay.
I have a question.
Okay.
So if somebody in the chat room wants to know, do you always get your own, or are there instances when you get someone else's baby blood cells or bone marrow?
Yes, so
whatever?
in the past, we have done from other people. And to do this is called allogenic transplantation if you use other people's cells. And the purpose for that kind of transplant is a little bit different because by getting other people's cells, you're getting a new immune system to fight the cancer. But it's much more toxic. So currently we are not doing this using other people's cells to do a transplant.
Okay. And then while we're on that same subject, is there any physical pain with this then? Since you said it's basically just a blood transfusion.
Well, the transplant itself, most people don't feel anything. It's just a blood transfusion. What's tough about is, I think there's two aspects that's tough. It's not the physical toughness, but who could really go in the study? These are young people. You have to be in good health, and the disease has to be well controlled. And that's not many, right? So that's just getting to achieve that hurdle is one toughness. And then the second toughness is that because you're giving a strong chemotherapy, so you could have nausea, you could have vomiting, people could get damage to the heart, to the lung, which is not common, but still these could happen, and your immune system could be low for a short period, which could result in the worst scenario, people could die from the treatment. So this is not for everybody, is what I want you to understand. But there are people with inflammatory breast cancer patient who has metastatic disease, went through, disease is controlled more than 2 years, and there are these unique situations could happen also.
Okay. There was also another question, if I could keep going.
Yeah, you've got. We're gonna leave in a couple of seconds here, so why don't you hold off?
Okay.
Dr. Ueno, we're going to take a short break, and we'll be right back.
Okay.
In a moment.
Don't go away. We'll be right back with IBC Facts and Fallacies after a few short messages.